Good morning, everyone, and welcome to our first grand rounds of May. Happy Cinco de Mayo to everyone. And May is Asian American and Pacific Islander Heritage Month. We are so happy that you've all joined us today from near and far. You can't see, but I'm wearing enormous shoes right now, those of the good Dr. Errol Azdaga, who is not able to moderate today due to his medical executive committee duties. Today, I have an even better idea of how amazing of a job Errol has done throughout the entire pandemic. Dr. Pinsky?
Thank you, and good morning, everyone. I'll talk briefly about the variants that we're seeing at Stanford. So here's our graph that I've shown the last few weeks. Our variants are relatively stable over the last 3 weeks. The B117, our UK variant, is the most predominant variant in our patient population, shown in green, the top line on the right. And then the California variant was overtaken about a month ago. And that is the second most common variant. That's B1427, B1429, containing the L452R mutation. So keep those letters and numbers straight. The blue line here is the everything else. This includes lineages that don't have any of the mutations we screen for, as well as a handful of the B1617 mutant originally identified in India. We've only had about 2 more cases since the previous report, so that has not taken off here as of yet, and hopefully will not. In addition, this blue line includes some P1 cases, the variant originally identified in Brazil. We have not seen additional cases of the South Africa variant or B1351 for several months. So that is the update for this morning. Oh, just one more thing briefly is that the infections in fully vaccinated individuals from occupational health that Brian was mentioning, those infections typically mirror the variant composition, the variant prevalence in the population. So we're not seeing those individuals more likely to be infected by a variant of concern. And we'll have more data on that in the coming weeks. So thank you, everyone. And that's my report for this week.
Thank you both so much for those updates. I just want to start with a peek at some of the wonderful grand rounds that we can look forward to in the upcoming weeks. Next week, Dr. Sarah Rudman will be giving us some updates on Santa Clara County. And the following week, we'll see the art of COVID command, from school reopening to controlling nation's borders. That is by Dr. Jason Wong. And then we'll round out Asian American Heritage Month, Pacific Islander Month, with Native American Pacific Islander Health presentation by Dr. Marjorie Mao. As we continue our theme of Inclusion 2021 in our department, I want to start off by acknowledging the COVID-19 situation in India. Of course, our hearts go out to all those who have been affected by the unthinkable surge of COVID in that country. We take so much from Indian culture and have so many Indian colleagues who are personally affected by this that I just want to take the opportunity to encourage everyone to contribute in any way you can, whether that's donation or otherwise. You can also check out a recording of last week's grand rounds. Today, as we focus on Inclusion 2021 in this very special month of AAPI Heritage, we are absolutely thrilled to have 2 of our very treasured colleagues presenting on Asian health, past, present, and future. Dr. Latha Palaniappan is an internist and clinical researcher who focuses on the study of diverse populations, chronic disease, and prevention. She received her bachelor's and medical degrees from the University of Michigan's Integrated Pre-Medical Medical Program. She started her clinical career with Doctors Without Borders in East Timor in 1999. Dr. Palaniappan came to Stanford in 2000 for her postdoctoral fellowship in Stanford Prevention Research Center and received her master's in epidemiology in 2001. Very impressively, she has been continuously funded as a principal investigator for 2 decades and has received over $20 million in funding for her research from the NIH, the American Heart Association, the American Diabetes Association, and other foundations. She was recently awarded a leave in service by Stanford Impact Labs and the Haas Center Public Service to work with nonprofit partners in India to impact chronic disease prevention in schools, communities, and workplaces. She co-founded, along with Dr. Bryant Lin, the Center for Asian Health Research and Education, CARE, at Stanford in 2018. I had the honor of meeting her and getting to know her in my space group several years ago. Dr. Bryant Lin made his way to Stanford after a stint at Tufts, where he received his MD and completed his internal medicine residency. He started trailblazing at Stanford as a research fellow and postdoctoral scholar in cardiology, focusing on cardiac electrophysiology. And he was also a biodesign innovation specialty fellow in the Department of Bioengineering. He's had many clinical teaching and administrative credits, but I do want to give them time to speak, so I'll name a few. He is the training director for the Joe and Linda Chapati Decide Center, as well as the head of education at Stanford Digital Health. He also founded DFarm, which is a nonprofit that introduces teens to design thinking. He still finds time to precept internal medicine continuity clinics for the residency and has numerous patents to his name. As aforementioned, he is the co-director and co-founder of his co-presenter today of the Center for Asian Health Research and Education. Many of you have seen him more recently this past year as he co-hosted and co-founded the Stuck at Home concert series during the pandemic. Doctors Palaniappan and Lin, welcome. Thank you for joining us today.
Great, thank you so much for that kind introduction, Dr. Dunn, and looking forward to you performing at a future concert for us as well. Dr. Palaniappan and I are really happy to be invited this month, Asian American Pacific Islander Heritage Month, to present our talk on Asian health, past, present, and future. We have no relevant disclosures to report. Today, we'll review the backgrounds of Asians in America and Asian health in America, excuse me. We will talk about the Center for Asian Health Research and Education, CARE, at Stanford that we founded. We'll review a COVID discrimination study we conducted last year. We'll also review the socioeconomic and health differences among Asian subgroups. And talk about normal weight diabetes in a specific study on precision exercise prescriptions for Asians. And we'll also end with future directions in Asian health. Inspired by Dean Michael Liu from the University of California, Berkeley School of Public Health, who gave grand rounds a few weeks ago, I wanted to talk a little bit about how the history of Asian migration to this country has affected me personally. As Dr. Liu talked about, there was a Chinese Exclusion Act that really prevented Asians and Chinese from immigrating to the US. It was repealed in 1943 by the Magnuson Act when China became an ally of the US during World War II. However, the act only allowed a national quota of 105 Chinese immigrants annually. My father, luckily, in 1962, was one of those 105 immigrants. He always tells this story. So this is my dad on the left. He's sporting his best James Dean look there, very popular at the time. And he always tells us a story about how he was invited to meet John F. Kennedy at the White House because there were so few international students at that time, but he didn't go. So I always told him, why didn't you go? He didn't have enough money and couldn't get a ride to the White House on that day. But luckily, I was able to recently mine the Kennedy archives and find this documentation, and I actually found my dad's name on the invitation list. This is him, Lin Chao Min. You lived on actually University Boulevard in Adelphi, Maryland, going to Maryland University. And as you can see here on this handwritten invitation kind of roster, I don't know if you can see this, from China, so predominantly it was from Republic of China or Taiwan at the time, and some from Hong Kong. There were only 36 students from in the greater DC area who were in the area at that time, And you can see down here, there are only 93 people from India at that time, 93 students. So times have really changed. It's incredible. I mean, there are probably thousands and thousands in the greater DC area now of immigrants from China, India, and greater Asia. Students from China, India, and greater Asia. This brings us up to the current day. So at Stanford, I just wanted to give you an idea of Asian Americans at Stanford. So Stanford really has this great dashboard where you can see the demographics of people at Stanford. So the greenish bar are Asians, about 20, and this is in the medical school, about 25% of graduate students in the medical school identify as Asian. 11% of postdoctoral scholars, that may seem low to you, but a large percent, 58% of postdoctoral scholars are international. And I'm assuming most of those are probably from Asia. Of the professoriate in the medical school, 24% are Asian. And over 30% of the staff are Asian at Stanford. So really, a strong Asian presence at Stanford. So really, again, happy to represent the community here today. So backing up with a global view, 60% of the globe is Asian. 6% of the US is Asian. But 30% of the Bay Area, and this is actually consistent among all the major counties in the Bay Area, are Asian. So that leads us to why Stanford really is an ideal place to study and educate the future leaders in Asian health. So, if I were more organized, I would have asked for a poll to be distributed, but, not being so organized, I didn't do that. But if you could do me a favor and take a guess. So out of all the NIH funding, so as you all know, most of the research funding comes from the NIH in the United States. What percentage of NIH funding, so if you could put it in the Q&A, is dedicated toward Asian health? So we'll give you a minute to do that. What percent of NIH funding supports Asian health? Well, I don't know if that'll be, we'll see if people will submit something in the Q&A. Just take a guess, put it in the Q&A about what you think. So somebody said 5%, 40%, 5%, 70%, 4%, 6%. Okay, the closest guess was the 0.01%, although that's an underestimate. So that's an underestimate. So we're actually better than 0.01%, but we are at 0.17% of NIH funding goes to Asian health. So really a tiny percentage. And as you recall, 6% of the US population is Asian. So we'll talk about, I'm a clinician predominantly. I practice primary care and PCPH. And let's talk about a clinical case that really inspired me. This case happened, this is my patient. He's been very supportive of our center. I would call him the inspiration for our center. And he agreed to share his picture here. He's was a 74-year-old man at the time with recurrent gout and opted for prophylactic treatment. I prescribed him allopurinol. He unfortunately developed DRESS syndrome, drug rash, eosinophilia, and systemic symptoms. He was admitted hospital. He was admitted, put on high-dose steroids, and luckily recovered. But he had this severe skin reaction that occurs in people of Han Chinese descent to allopurinol. There's no indication, there's no mark on the FDA label indicating increased risk for certain subgroups for allopurinol. So just to review a little bit of the statistics around this and a little bit of the information. So the reaction, the risk of allopurinol-associated severe cutaneous adverse reactions, including DRESS, Stevens-Johnson, and other skin reactions, highly correlates to HLA-B5801. This was a study of about 400,000 people. And you can see the overall prevalence of HLA-B5801 is definitely significantly higher in Asians and African Americans. And as well, the risk of allopurinol-associated severe cutaneous adverse reactions is much higher in African Americans and Asians as well. So it really inspired me, as well as my already previous knowledge about differences in Asian health in Asians and Asian subgroups. I reached out to our local community at Stanford, and of course, Dr. Samso, our colleague in the Department of Surgery, has been working on Asian health for over 25 years. We're really standing on his giant shoulders. I know Dr. Dunn talked about big shoes to fill, and so we also have big shoes to fill. Dr. So has been really leading efforts to end hepatitis B and end liver cancer, and has had a very distinguished career and continues to have a distinguished career in this area. Most recently, he helped push AB 7809 through in California in the Assembly that will require primary health care facilities to offer voluntary hepatitis B and C screening for all Californians and provide recommended care and treatment for persons who test positive. So this is an example of how his efforts, even though they started with the Asian community, affect all people in the community, all Californians. So with that, Dr. Palaniappan and I put our heads together in 2018, and we founded Stanford Care, Center for Asian Health Research and Education, really well supported by the community, the local Silicon Valley community, as well as folks in the arts and other areas. We had Wayne Wong was on our advisory board, John Roos, among many others. John Roos was the former U.S. ambassador during the Obama administration to Japan. Parveen Jain, Anita Wesley, and of course, great support from Dean Lloyd Minor as well as Bob Harrington. Our vision is to become, no small task, the premier academic leader in precision Asian health. Our mission is to improve the health of Asians really everywhere. And our goals are threefold: to increase research and knowledge, educate patients, providers in the community, and to improve the culturally sensitive and, of course, evidence-based delivery of precision care. As well discussed by Dr. Liu a few weeks ago, we are experiencing a rash or a rise in anti-Asian hate crimes. The Pew Research Center last June just conducted a study looking at the impact of COVID-19 and racism. So if you look here, they asked people questions on whether people were acting uncomfortable around them due to their ethnicity, whether there were slurs or jokes, whether they had fear of physical threat. You can see here, using, for example, the white population as a comparator, 13% of whites responded that people acted uncomfortable around them, compared to 39% Asians. Of course, in the Black community, quite high as well, at 38%. And in terms of fear of physical attack, the white population reported 9% having fear of physical attack due to their ethnicity, compared to 20% of the Black population and 26% of the Asian population. So, inferring an odds ratio, in medicine, we talk about odds ratio. So an implied odds ratio would be about 3 times the risk for Asians acting uncomfortable around them, and a little under 3 times the odds of fear of physical threats or physical attacks. There are a few significant problems with this survey. Most of all, they only included 278 Asian American respondents, and they did not disaggregate Asian American subgroups. So led by our students, Sierra Han and Nguyen, who were undergraduates and co-term students at Stanford, they led a study examining self-reported discrimination and concern for physical assault due to COVID-19, again, last year. We had performed a nationwide survey, 1,800 respondents, looking at self-reported discrimination, asking about concern for physical assault due to COVID-19, as well as really looking at subgroups. We wanted to make sure that we disaggregated Asians. We used a convenient sample distributed on Pullfish and email listservs, oversampling for Asian Americans. So here's what we found. So in terms of self-reported discrimination, Chinese, Korean, Japanese, Vietnamese all reported higher rates of discrimination. The rates range from adjusted odds ratios ranged from 3.1 in Japanese Americans to 3.9 in Vietnamese Americans. So again, if you remember the numbers from the Pew study, there are around 3 times versus this, we had up to 3.9 times the odds in Vietnamese Americans. And as you can see, there's a lot of heterogeneity among the Asian subgroups, and most notably, some differences in East Asian versus South Asian and Filipino backgrounds. If you look at concern for physical assault, the numbers were quite different from the Pew study. The adjusted odds ratio were as high as 4.4 in our study, 4.4 times in Chinese Americans, and 5.4 times in Vietnamese Americans. And as you remember from the Pew study, those ratios were, inferred ratios were around a little under 3. So quite significantly different results, and really, again, highlights the importance of disaggregating subgroups of Asians. So in summary, we found higher anti-Asian discrimination than previously described in some subgroups in particular, Chinese, Vietnamese, Korean, among others, and disaggregation really revealed great differences in heterogeneity among subgroups. And we felt there needed to be more studies on concern for physical assault. There's really a paucity of literature in this area. If you want to look at our preprint, you can look at medRxiv, and we submitted the study to the Journal of Asian Health, which Dr. Palaniappan will discuss later. There's been a recent study since Dr. Liu's, recent survey since our studies and since Dr. Liu's talk a few weeks ago. Pew Research conducted a study specifically on violence. 8 in 10 Asian Americans say violence against them is increasing, and 1 in 5 US Asians cite former President Donald Trump as one of the reasons for the rise in violence against Asian Americans, as you can see here. However, there is hope around the corner. The United States Senate led by the senator from Hawaii, has passed almost unanimously, I think they missed one vote, a new anti-Asian racism bill to support anti-racist efforts, anti-Asian racism efforts by the federal government. So hopefully that will get passed by the House as well. So I want to wrap up my portion of the talk with talking about our students. Really, our student community has been very active. Again, led the study that I just talked about. The Asian Pacific American Medical Student Association, PAMSA, they met with Stanford School of Medicine faculty on April 16th, and Dean Lloyd Minor and Dean Gesundheit. They discussed specific areas of improvement, constructive improvement to improve anti-racism in the School of Medicine in its educational efforts. Talked about student well-being, anti-racist policies, processes, and increase in sustained DEI efforts. I know several of you are involved in these efforts. Really applaud the excellent presentation, and I learned a lot from them, from Vivian Liu and Richard Lang, who are medical students, and really great thanks again to Dean Gesundheit, Dean Minor, as well as Dr. Harrington for their support on these efforts. With that, I'm going to hand it over to my colleague and co-director, Dr. Latha Palaniappan.
Thank you, Dr. Lin. And thank you, Dr. Dunn, for inviting us today and acknowledging the global crisis that is going on in India now. The Center for Asian Health, Research and Education is collaborating with our partner, the American Association of Physicians of Indian Origin. We put out the link in the chat, again, if people want to contribute in any way that they can. Next slide. I'm going to start by talking about my father's story. So my father immigrated to the United States in 1974 as a PhD student at the University of Detroit in engineering. I was 3 years old at the time. He died 10 years later in 1984 of a heart attack, and I was 13, he was 39. And when I was looking for data on higher risks of heart disease in South Asians, there wasn't any available because Asians in 1984 were often omitted from healthcare data. When they were studied, they were often aggregated and important signals were missed, as Dr. Lin showed you with the discrimination data. And if they were included, one group, such as Japanese, were studied, and those findings were applied to very different groups like South Asians. So this led me on a path to try to study Asians in America better. Next slide. So these 6 origin groups make up 85% of all Asian Americans: Chinese, Indian, Filipino, Vietnamese, Korean, and Japanese. So these 6 groups are enumerated on our US Census and death records. As you can see, there are many groups that are part of Asia that are not enumerated on the census. And it is important, if you have ancestry in one of these groups, to write in your ancestry so we can strive to do better data collection in these diverse Asian subgroups. Next slide. Asians often have the model minority myth of being highly educated, high income, high socioeconomic status. And I want to show you just a little bit of data on the variation in median household income. At the top level, if you examine all Asians compared to all Americans, you can see that the median household income is higher. However, there is much heterogeneity among the Asian subgroups, and we must strive going forward not to confound race, ethnicity, and socioeconomic status, and really separate these variables in our analysis. And these are similar patterns that we see for education as well. Next slide. Asians are underrepresented in clinical trials. On the pie graph on the right-hand side, as Dr. Lin mentioned, Asians make up 60% of the world's population. And you can see that they're underrepresented in clinical trials of drugs that we use. So thanks to Dr. Linda Barman for her questions in the chat about statins and ACE inhibitors in Asian populations. The truth is, Asians are underrepresented by a factor of 5 in the drug trials, and therefore we don't have enough data to understand the toxicities, as Dr. Lin mentioned, and we're just at the tip of the iceberg in terms of understanding pharmacogenomics in Asian populations. Next slide. Genomics is also failing on diversity. So these are studies done by our Stanford colleagues, both in 2009 and 2016. And you can see that Asians are even currently underrepresented by a factor of 3 when compared to the world's population. And this affects genetic prediction that we can do in Asian populations. So at CARE, one of our goals is to increase Asian participation in research, both in clinical research as well as genetic and other omics research. Next slide. So as physicians in the Bay Area, we are making decisions about Asian health, mainly using non-Asian data. And this is something that we hope to change at the Center for Asian Health Research and Education. Next slide. It is important to study diverse race ethnic groups, and I applaud the Department of Medicine, Dr. Harrington, for their diversity and inclusion efforts, because we learn a lot from studying diverse population, and it will help us achieve our goal of precision health. There are differences in disease patterns, clinical presentations, and therapeutic response that vary dramatically by race, ethnicity, and ancestral background. We see this in biomarker prevalence, with lung cancer genetics, with KRAS mutations being more common in European ancestry, and EGFR mutations more common in East Asian ancestry, with differences in drug safety and efficacy, as we saw with Dr. Lin's example of allopurinol, with asthma and variable efficacy of beta agonists in those of African ancestry, and in seizure disorders for carbamazepine in Asian patients with a boxed warning for those with HLA-B1502, which causes increased skin reactions, also as Dr. Lin described. And it can help us make new scientific discoveries, as in the case of breast cancer, where a genomic study of Latino women led to discovery of novel protective variants. The study of diverse populations can help us understand disease pathophysiology, discover new treatments, and personalize care for our diverse populations. Next slide. We're fortunate at Stanford to have a deep bench of researchers that are studying differences in Asian health across the lifespan. And we are just at the beginning stages of all of these investigations, starting with Asian infants who have a 40% increased mortality rate due to maternal complications, led by Dr. Susan Carmichael and Jochen Profit. We mentioned Dr. Sam So, who's dedicated his career to studying hepatitis B and liver cancer. Our psychiatry and psychology colleagues looking at depression in Asian American populations, which is much less frequently reported. Our colleagues, Dr. Gross and Dr. Chen, who are looking at the East Asian flush, secondary to a variation in the ALDH2 gene. Normal weight diabetes, which I'll tell you a little bit more about that scientific story shortly. Our colleagues at the Sathi Clinic who were studying earlier heart disease in South Asians, led by Dr. Raj Dash, Dr. Alba Khandawal, Kiran Barjosan, Shiram Nalam Shetty, and Fahim Abbasi. And then the higher risk of gastric cancer being investigated by Dr. Juha and Robert Wangs, respectively. So as I said, we are uniquely positioned at Stanford, given our diverse population and real depth and breadth of research to make differences in Asian health. Next slide. I want to talk a little bit about transnational comparisons and what we can learn from them. I'm going to start with cardiovascular disease. So cardiovascular disease mortality varies widely in Asian countries, from a low of 24% in Korea to a high of 43% in China, with the US at the midpoint at 32%. Next slide. I'm going to take two examples. First, China, and then India. Both of these countries have 1.4 billion people each, and combined make up 1/3 of the world's population. In China, when we examine major cardiovascular disease mortality, it is stroke predominant. 54% of people who die of stroke, and 46% of people who die of cardiovascular disease die of heart disease. In contrast, when we look at immigrants with ancestry from China, Taiwan, or Hong Kong, we see that heart disease is predominant at 74% compared to 26% of stroke, and this more closely approximates what we see in non-Hispanic white populations. In contrast, from India, heart disease is the predominant form of cardiovascular disease death, with stroke being less prominent at 32%. In immigrants from India, like my father, heart disease is the predominant form of cardiovascular disease, and this occurs much earlier, as we're finding, and stroke is a much less common form of cardiovascular disease. So studying these gradients of disease in immigrant populations compared to countries of origin and compared to other diverse populations in the US offers us opportunities to contrast and understand contributors to unique disease burdens and advance the frontiers of precision health for all populations. The exploration of reasons for these differences in cardiovascular disease gradients offers rich opportunities to study genetic, environmental, and cultural variations that may underlie these distinct mortality patterns. Next slide. Now I want to move our discussion to cancer, which also has an interesting patterns. So cancer mortality varies from a low of 10% in India to a high of 33% of deaths in Korea, with the US, all race ethnic groups aggregated at 26%. Let's take two examples here. First, we'll examine Vietnam. In Vietnam, 18% of all deaths are due to cancer, and liver cancer makes up 2% of all cancer deaths. For non-Hispanic whites in the US, 1 out of 4 deaths are due to cancer, and 2% of these cancer deaths are due to liver cancer. In contrast, Vietnamese Americans, 1 out of 3 have cancer as a cause of death, and 16% of these cancer deaths are due to liver cancer. So this is overrepresented by a factor of 8. In Korea, we see a similar pattern with 1 out of 3 deaths being due to cancer, with gastric cancer as 12% of these cancer deaths. In non-Hispanic whites, gastric cancer makes up 2% of cancer deaths. And for Korean Americans, this is overrepresented by a factor of 7. So this gives us opportunities to identify and learn from these high-risk groups in the US to help us make new scientific discoveries and identify new pathophysiologic mechanisms and treatment strategies. We may also consider implementation of successful international screening strategies, such as gastric cancer screening, which has been successful in lowering gastric cancer mortality in Korea. And these efforts are being led by Dr. Juha Wang. Studying high-risk groups, identifying high-impact clinical strategies, and implementing policy changes can improve outcomes for all populations, as evidenced by the B and C screening strategies pioneered by Dr. Sam So, who is now creating positive policy changes for everyone in the United States. Next slide. So we have at the Center for Asian Health Research and Education been able to use big data in Asian health using national data sets, international mortality records, and electronic health records to uncover consistent signals on health. And I'm going to be talking a little bit about a scientific story on one of these scientific signals that we've discovered. Next slide. So diabetes is very prevalent in the United States at about 13% of the population. One thing that we have been noticing, and I'm sure you've seen in your clinical practice, is that Asians tend to develop diabetes even at normal levels of body weight, so body mass index of less than 25. And this is work that I and others have done showing that prediabetes as well as diabetes is higher for Asians at all age groups and every BMI level. Next slide. The prevalence of normal weight diabetes is higher among diverse race ethnic groups in general, and particularly among older ages. The high risk of diabetes at low BMI may be due to factors beyond just obesity. Next slide. We've also seen an obesity paradox. So this is work done by my fellow postdoc at the Stanford Prevention Research Center, Dr. Mercedes Carnathan, who showed that adults with normal weight diabetes have double the mortality rate of those who are overweight and obese. And this was theorized to be partly due to adiposity, the amount of body fat that we have, particularly in metabolically active fat depots such as visceral fat, or relative sarcopenia, or less muscle mass. And we had not yet explored the effects of physical activity on body composition and total body fat in normal weight diabetes, which is a clinical problem that is overrepresented in our population specifically. Next slide. So the majority of global diabetes prevention trials enroll overweight and obese individuals. There were no trials of prevention in normal weight individuals, who make up 10 to 20% of those with diabetes, as we saw in the previous slide. The United States Preventive Services Task Force for Diabetes Screening recommends using overweight obesity as the main screening criteria, and this misses a substantial number of individuals, especially those in race ethnic minority groups, as we saw. And the data on the most appropriate treatment strategies in normal weight diabetes is scarce, and we don't have adequate recommendations for prevention and treatment. Next slide. And the current American Diabetes Association guidelines emphasize aerobic exercise, and I'm sure all of you have counseled your patients. 70% of people in the United States don't exercise enough to simply start walking. Next slide. I want to thank the Strong D team who are all listed here. Next slide. And I want to spend a few moments talking about future directions of care. Next slide. We've been fortunate to have a robust conference schedule in the 3 years that we've been in existence, with conferences dedicated to gastric cancer, evidence-based traditional Asian medicine, and the International COVID Conference, which was put on last year in May and will occur again in May 14th. We put out the link in the chat, and this is co-sponsored by the Center for Population Health Sciences, the Center for Innovation and Global Health, and the Center for Digital Health. And I want to acknowledge for the Evidence-Based Traditional Asian Medicine Conference the tremendous support by the Chi Li Pao Foundation and Dr. Gloria Kim for bringing these therapies, which 1 out of 3 of our patients use, into the mainstream of scientific evidence and discovery. Next slide. I want to thank our leadership for support of this new center. Both Lloyd Miner and Dr. Harrington have been very generous with their time in supporting these events and our students. Next slide. We've partnered with the Stanford Health Library in community talks, and we're also sending out the links for these community talks there. And I want to acknowledge the many collaborators in these community talks, including Dr. Aruna Subramaniam and Dr. Ann Singh and Dr. Fumi Aikino. Next slide. I want to let you know a little bit about the science that is going on. We started a seed grant program in 2019, and you can see the wide variety of projects that are being pursued by our investigators. We've had over 100 seed grant applications for Asian health in particular, studying everything from pharmacogenomic differences to thyroid cancer to emergency medical therapies and abdominal aortic aneurysm. So we're looking forward to the results of this science in order to apply them for precision health. Next slide. I want to thank Dr. Malathi Srinivasan for directing our very successful CARE Summer Scholars Program. She has pivoted to online for a 9-week summer immersion program in data science in vulnerable populations. And these students have been very successful in creating science in peer-reviewed journals, which will improve the pipeline in Asian health going forward. Next slide. And also thanks to Dr. Paul Wang, who's editor-in-chief of the relaunched Journal for Asian Health. We hope to have our first relaunched issue in July 2021 and have 2 issues a year to start to contribute to the understanding of social and medical determinants of health in Asians in the US and elsewhere. Next slide. So in summary, we have just started with Asian health with physicians, researchers, community health advocates, and the generous support of our philanthropic community. In 5 years, we hope to positively impact our community through educational efforts and engage other stakeholders. And in 10 years, we hope to make inroads into clinical recommendations, changes in health policy, and create a sustained funding environment so that in 20 years, we can say that Stanford was a leader in improving Asian American health outcomes. Next slide. So we invite all of you to collaborate with us on studying Asian populations, which are uniquely Stanford. So we have put out the web link in the chat. It's care.stanford.edu, and want to highlight just for a moment a few of our upcoming conferences, including on May 14th, the International COVID-19 Conference Lessons Learned, the Community Health Talks coming up, and also the Stuck at Home concert led by Dr. Bryant on May 20th, celebrating Asian grandmothers. Next slide. So we're looking forward to your questions, and thank you for your attention and for your time today.
Thank you both so much for that wonderful presentation. There are some questions in the chat. We'd actually like to start with Dr. Ahuja has a question from the panel.
Thank you, Tamara. Latha, I really appreciate your very well-rounded talk. I've heard you speak over the years, and your compelling science and your background and the personal touch you put into your talks is superb, so thank you. My question to you is, you mentioned earlier in the hour that there is a lower recruitment of Asian Americans into clinical trials. And I'm wondering if the strong emphasis on Western medicine for this group, Ayurvedic medicine, et cetera, might be preclusive from them being interested in enrolling. What are your thoughts on that?
I think that's a great point, Dr. Ahuja. Thank you for your question. I think that we need to do a better job in the medical community about addressing the barriers to participation in clinical trials. Some of the barriers to participation are similar for diverse race ethnic groups in general, in terms of less time, for instance, childcare issues, being able to have the understanding of concepts that may be more prevalent in Western cultures, like randomization, for instance, flipping a coin, getting a placebo. And these concepts may need to be better communicated to diverse populations in order to engage them in medical research. Also engaging our communities and feeding back to our communities our research results, and the importance of participating in medical research so we can understand pharmacogenetic differences, for instance, that were brought up earlier in the talk.
Yeah,
Thank you. Thank you.
Thank you so much. There's been a lot of talk about race-based medicine at this time. And one question was, how do we go about dismantling race-based medicine and its negative effects, but acknowledge, of course, and pursuing the links between certain conditions in Asian Americans, like gastric cancer in Koreans?
Dr. Lin, do you want to take that one on, or I can?
I mean, I think it's definitely a tightrope. I think it's interesting looking at, from different communities and backgrounds. I think you need to look at the positive things and what interventions we can have. So I think focusing on screening, like Dr. Samso has done, is an effective way of not necessarily, bringing in the negative aspects of race-based medicine, but really a population health approach, which is more on what populations are at risk that we need to screen. So I think that's a place to start. I don't know if I have the great answer for that. Do you have any other thoughts, Dr. Palaniappan?
Well, just adding to those excellent comments, I think that we all want to be the best doctors that we can possibly be for our patients. And the fact is that we don't have enough data on all of our patients, not just Asian, all race ethnic groups. And we need to strive to study these diverse groups. And we have learned a lot by the studies that we have done, as I showed in the slide, of understanding differences in KRAS and EGFR and protective variants for Latino women and breast cancer, and the pharmacogenetic differences that we talked about with beta agonists and HLA variations with carbamazepine and allopurinol. And Dr. Meitner put it really well, Dr. Lloyd Meitner, when he spoke, that we will never have precision health until we study all populations and understand all of these variations in disease. And as I said, we're just at the tip of the iceberg, and we do need to go several layers deeper. And it's not something that we'll solve next year, but hopefully we'll be able to take some important steps forward and hand off the baton to the next generation, because there's lots to do.
Great. Well, it is 9 o'clock, but we have a few questions. If you're available to stay for a few minutes more, we can go a little over.
Sure.
Great, thank you. So Dr. Ash asks, well, first he says, wonderful work. And what are the best implementation strategies to increase gastric cancer screening in high-risk Asian Americans?
I think we can channel Dr. Huang, our colleague, on this, and his view, and he's the expert in the area, and him and Dr. Robert Huang are to, since everybody's undergoing colon cancer screening, to get the upper endoscopy at the same time. His approach has been to advocate for getting an upper endoscopy at the same time as getting your initial colonoscopy. Of course, then for people getting stool screening, we don't have an alternative for that. So that is a gap there. So I think more research needs to be done on something equivalent to the stool screening test for gastric cancer. But typically, a single screening should be sufficient to determine whether you're high risk or not, whether you need to get additional endoscopies or not.
I'll add to that a little bit and shout out to Dr. Robert Wang in the audience. He recently got a Career Development Award with a score of 10. I hope you don't mind. That is the best score that you can get on a grant. And he is using big data approaches to mine electronic health records to create a score for whether people should get upper endoscopy screening or not. And it will include as one of the factors, race ethnicity, so identifying high risk race ethnic groups like Korean Americans, but also other biological screening like H. pylori test positivity, for instance. So it might not mean that everybody gets an EGD as we do with colonoscopies, but that the primary care provider can, with the touch of a button, understand who to refer for EGD so we can provide precision health.
Great, thank you. And last question from Dr. Garcia, asking about whether all aerobic exercise regimens are equivalent, such as swimming versus walking versus running.
So that's a great question, and we did not study that, and I would love to know the answer to that. And I am not aware of any studies that have specifically studied, for instance, swimming versus running in terms of diabetes risk. However, our study did show that particularly as people get older and they have sarcopenia with aging anyway, and 80% of the insulin-mediated glucose uptake in the body is through muscle, that instead of thinking about just excess adiposity, we might pivot to think about increasing muscle as a sort of positive change to decrease glucose.
Wonderful. Well, there is one more question about whether or not anyone has studied the difference in Asians being able to tolerate anesthesia. Are you aware of any of those studies?
So I'll start. I know Dr. Eric Gross is specifically studying variation in aldehyde dehydrogenase 2 variants and anesthetic response. And I will say that there are differences, but I will not take the wind out of his sails because I hope he does a grand rounds on that soon.
Great. Well, thank you both so much for that presentation. We really appreciate it. It was fantastic. And that concludes our grand rounds for today. Happy AAPI Heritage Month, everyone. We hope you'll join us later on in the month as well. And we have some great grand rounds upcoming. So thank you, and everyone have a great day.